Okay.
Okay. Let me welcome you to the program as well. I'll tell you something that I read an article some time back that stated that once you remove mandatory continuing education, short online courses, only 3% of American therapists doing orthopedics anyway, actually engaged in continuing education. So you're well ahead of the curve. You want to learn, we want to teach you, and we want to take the credit for you learning. So kudos. Let me just reiterate what Dave said. Don't treat the videos like a documentary. These are lectures. You're going to have to study them like a lecture. You're going to have to take notes. You may have to watch them more than once. You're going to go back and pick out bits and pieces that weren't clear, but treat them like lectures. Now, you can't ask questions then, but you can ask questions on the next Zoom session. So ask a question. All right. Now, if you don't want to ask the question while we're live, you can email me. I'll give you the same email address we used last time, Q&A@Gmail, and you can email me the question, then I'll address that on the Zoom session. So use them as lectures, all right, not as just entertainment. They're not exhaustive. Those videos are not exhaustive. If they don't leave you with questions, there's something wrong. There's probably going to be more questions after you've watched them than answers. They're a 15-minute presentation or 20-minute presentation on something that should take 2 hours. So they're a skeleton to work around. So please ask questions. There is no failure in asking questions. The failure comes when you don't ask a question when you should ask a question. So every time you get something wrong or every time you ask a question, you learn from it. So please engage in the Zoom session and you will do better with it and you'll enjoy the Zoom sessions more as well. Just engage. Treat these like tutorials. They're discussions and it'll be initiated either by you or by the mediator of the Zoom session, and then it should continue on from there. Otherwise, what you're going to get is instructional lectures and they bore everybody. So get involved in the process. You're going to enjoy it a lot more. What else was I was thinking of? The glossary of terms. I'd like a bit of help from you if you would. I don't know how comprehensive that is. So if you can think of something that's a bit outlandish, all right, that you wouldn't normally associate with manual therapy, see if you can find it in the glossary. If you can't find it in the glossary, email me and I'll put it in the glossary, all right? This is the only way that glossary is going to get more comprehensive. Right now it's running 180 pages, so it's pretty comprehensive. Now it's a detailed glossary. There are references in there and more than just the definition of the term. So as I say, if there's something that's not in there that you need in there, let me know and we'll put it in, okay? All right, now the Zoom sessions. The first module, possibly the second module, will be about the process of diagnosis. And we're going to dive into it a little deeper than you probably have done before. And we're going to look at the processes that you use. Whether you know you're using them or not, we're going to dissect those processes, try and make them a little bit more superficial, and then have you know what you're using when you're actually making the diagnosis. And then you can figure out what's gone wrong with the diagnosis when your treatment's not working. Do you have any questions for me before we get going? Any questions at all? Okay. All right. So I'm going to give you a really simple case. Okay. I need share screen, Dave.
Sure.
Thanks.
Give me a sec, hit the wrong button. Bam. You're good.
Right. Now, this is lateral elbow pain. If there's one area that I'm pretty sure that everybody's familiar with, it's lateral elbow pain. So let's see how we do with this. This is a 47-year-old man who's complaining of pain on the right lateral elbow. He's had it for 3 years. His doctor diagnosed it as lateral epicondylitis, which is tendonitis. It's not the inflammation of the bone. It's inflammation of the common extensor tendon. Anyway, he's been on anti-inflammatories for 3 weeks. There's been no change in it, and it's been referred to you. So what I want you to do is think about how you go about making this diagnosis. What's step one in your process, all right? All right, so I've got a list of names for you, starting from the top and coming down the bottom. So I'm not being nasty, I'm just picking the first one out. Kristen, what's your first step in making this diagnosis?
Can you hear me? Did I do that right?
Yeah, yeah.
Okay. I would go through their subjective history and how long it's been going on for, what aggravating factors are, alleviating factors are, and then do any like special testing for lateral epicondylitis.
Okay, so you're assuming that the doctor's diagnosis is correct.
I would assume it for the time being, but I wouldn't rule out anything else, like anything coming from like cervical spine or any possible like joint related versus just the common extensor tendon.
Okay. All right,
so I would go based off of their diagnosis, but think outside the box a little bit too.
Okay, thank you. Stephanie, what about you?
Can you hear me?
Yep, thank you.
I would agree with that. I would start with the subjective, kind of get, like she said, the aggravating factors, and then any improving like movements, if there's anything that decreases their pain at all. And then from there, I'd kind of go into objectives, test and measure.
Okay. Kevin.
Can you hear me?
Yep.
Okay, so I agree. I would start with the subjective. I would be also within that subjective, I would be asking them about what they've tried, what's been helpful, not helpful, just the course of the situation, kind of mapping out how it started, what's been done up to this point. And I would agree with, I would probably start with, beyond that, I would go number 2, probably palpation, kind of my basics, pressing the offending tissue. Does that match up? Does it elicit pain when I stretch it? Does it elicit pain when I load it?
Okay.
I would ascertain those things as well.
All right. Is there anybody who's going to do anything substantially different?
I think the only,
everybody's right. Sorry.
oh, I was just gonna say the only other question I was gonna ask would be like, was there any any significant like changes when it started or an injury associated with it,
Okay.
or any like life changes at the time
Right.
as well?
Okay, so the question is, what method of clinical reasoning are you using here? Do you know? Dan, any thoughts?
Is it deductive reasoning that you ruling it in, ruling it out? Is that what you're at? Is that what
That's
you're
actually
asking?
not deductive reasoning.
Okay.
Let's look at the types of clinical reasoning you can use here. One is pattern recognition, where you know what it is. You've seen it often enough that you know the outliers, you know the condition, so you recognize it immediately. There isn't enough of a pattern here to use that. Lateral elbow pain isn't a pattern, it's a single symptom, so there's no pattern. So you can't use clinical reasoning. A very experienced therapist who's good with this condition, if he got the next piece of information, it hurts when I grip, then he may well come to that as a pattern recognition. You haven't got enough for that, so you can't use pattern recognition, which isn't clinical reasoning anyway. That leaves you hypothetic, I'm going to use the wrong term here, hypothetic deduction or differential diagnosis. They're about the only two other ways you can do this. So what you're all humming around is hypothetic deduction. Is that all right? But you need a hypothesis. Now, the hypothesis you've chosen is the doctor's. Now, that's fine. The only problem with that is they've been 3 weeks on anti-inflammatory and there's no change. So what's the chances of this being an inflammatory condition? Patrick, what do you think?
I would think there is still a chance that it could be inflammatory if they're not modifying their activity.
Well, let's
at all.
assume they are. They've been told to take it easy. And in fact, with tendonitis, you can't do anything else. But take it easy. The first thing we should get together on is this, terminology again. Lateral epicondylitis is a really bad term. It implies, or it states actually, that the lateral epicondyle is inflamed. You don't mean that, do you? Does anybody actually think that's what's happening? I don't think so, do you? This is a common extensor tendon problem. Would you agree? Christopher, you can be the spokesperson here.
Yes, I do agree with that. It seems to
Okay.
be more of the tendon.
All right. Now, if the tendon is actually inflamed, it's a true tendonitis, you can't use that arm. It's so acutely tender and so acutely painful that gripping anything at all is impossible. This is not the lateral elbow pain that you normally see, is it? To get this, you need serious, unfamiliar overuse, direct trauma, or a medical condition to produce this. That's an inflamed tendon. What you deal with most of the time is tendonosis, degenerative changes to the tendon. Abby, what do you think of that statement?
Could you repeat that? My computer just froze. I'm sorry.
Okay. A tendonitis is an inflamed tendon. It's disabling. You lose function. You can't grip because it's so painful. You palpate the tendon and it's very superficial. You don't have to find the tender spot. That whole lateral elbow is severely tender. And it aches as well. So that's your inflammatory tendon. What you'll normally see is not that. You have to dig for the tender point. You have to do a maximal contraction to get pain usually at the elbow. Stretching usually doesn't hurt it. This is tendonosis, a degenerative tendon rather than an inflamed tendon.
Yeah, I think it kind of depends just because everyone's tendonitis is different and the way that they present is different. So yes, it's been 3 weeks, but would you call it tendinosis? Or could you call it a tendinosis only after 3 weeks?
Yeah, yes, absolutely.
Okay.
In fact, I doubt very much whether you see very many tendonitis at all. A degenerative tendon doesn't have to be painful. It isn't actually. A degenerative tendon isn't painful until it is. So degeneration doesn't occur suddenly. Degeneration occurs over time. And then you trigger the pain by doing something. Now that's not severe overuse usually. That is usually a one-off thing where you've just done something unfamiliar, but it's not serious overuse. Tendinoses tend not to be disabling. You can still use it, which we go back to with the first comment, was if they're not complying with you telling them to rest, it won't get better. That's quite right. But with a tendonitis, you haven't got much choice. You have to comply with that because it's so painful, you can't stress it out. So a tendonitis is a very, very acute disabling problem. A tendonosis, on the other hand, is very common and it's not disabling. So I think that's the first thing. You've got to differentiate degeneration from inflamed. A degenerative joint isn't painful unless it becomes inflamed because you sprained it or something. And then you get a bit of inflammation from it and it's a traumatic arthritis. But the degenerative changes in there are pre-existing that. Now this really becomes important when we're looking at manual therapy, because pretty much every joint that you're going to treat that is a mechanical dysfunction is degenerative and it's lost stability. What do you think? Stephanie, what do you think?
My only question would be, can there be different levels of tendonitis, or is it always that it's so inflamed that it cannot be used, and that's like kind of the only level of tendonitis that there is?
I think you're better off, yeah, you can have really severe tendonitis. You'll see that with things like rheumatoid. But so you can have a spectrum of tendonitis, but the difference between the tendonitis and the tendonosis isn't a matter of degree. The tendonitis is so much more, even a mild tendonitis is so much more severe than a severe tendonosis. The difference is obvious. It's just that we've got used to this term where a tendonitis is a catch-all phrase. So when basically you should, when you're looking at a tendon problem, what you have is a tendinopathy. And that tendinopathy encompasses all forms of tendon pathology, tears, inflammatory conditions, degenerative conditions, paratendonitis, and so on. They all fall under that term tendinopathy. Your job is to try and stage them. But the staging between tendonosis and tendonitis is pretty obvious. And I would guarantee that most of you have not seen many tendonitises. Most of what you've seen have been tendinoses. This is why anti-inflammatory treatments don't work. If you give good enough doses of anti-inflammatories to a tendonitis, there'll be some improvement. Otherwise, what you do, if I was a physician, if everything was a tendonitis, everybody would get steroids. It's a nice, short, quick treatment, and it works. But it doesn't work on tendinosis. Where are we? Ryan, you comment. Are you there, Ryan? Has he gone for coffee? Aurelia?
Yes.
Actually, is that Aurelia or Aurelia?
So it's actually Carolia.
Aurelia, okay.
Yes.
Got both wrong.
Can you repeat your question there?
No, I was just asking for a comment on the thing I just said.
In the thing that you just said, you
Oh,
said.
God knows, it went on. Let's see if
Brittany?
I remember.
I can't hear you. I'm so sorry, James.
You can't? Jim. Hey, good, I've corrected you about names. You're getting an echo from me, aren't you? Or I'm getting an echo when I'm talking to you. All right.
Yes, I'm hearing a little bit of an echo here.
Yeah, so am I. Violetta, you give it a shot, would you? Because it might be better.
Can you hear me?
I can. No echo.
Okay. No echo. Perfect. No, I just got my mind thinking kind of through tendonitis being that acute stage, and since anti-inflammatories weren't helping out the situation, it looks like we can rule that out, kind of looking more into tendinosis.
Well, you can do it in a minute. What I'm doing right at the moment is just pointing out the difference between the two. I just want to know how much of a problem what I've said for you is.
How much of a problem?
Yeah, like, do you agree with it, disagree with it, what?
I think I'm agreeing with it and thinking of my own clinical reasoning now as being a little different, or not different, how to change it.
Okay. All right, good. John?
Can you hear me?
Yep.
Yeah, so I was just kind of thinking about how we usually don't see the tendonitis initially. Typically, I mean, at least in my experience, and I think kind of what people do is they wait to see if it gets better, but then it could progress, more to a tendonosis from that. So I think that it is really hard to see that tendonitis initially, partially induced because a lot of people just wait, or it's something that happened a long time ago and they keep re-aggravating it, and then it turns into that tendonosis from there.
Yeah, you can certainly develop degeneration from an injury to the tendon. That is a very good way of doing it. An inflammation will degenerate tissue as well. But the actual presentation is what I'm interested in. It either presents as a tendonitis or it doesn't.
Right. I definitely agree with your definition there too. That makes a lot of sense to me. And I do think that, like you said, a lot of the people that we do see here are in that tendonosis stage, and they do present like you were talking about earlier there. And you really do need to load them typically to reproduce the pain. Whereas with the tendonitis, like you said, it would be acutely, painful, and we'd be able to tell right away.
Yeah, it wouldn't be, that's not a diagnostic problem at all. Is there anybody who has problems with what I just said? Otherwise, we're going to spend hours going through everybody here. Anybody got a problem with what I just said? Feel free to disagree, and I'll tell you exactly why you're wrong.
I don't know that I disagree. I just have a question. I guess I have a patient that was presenting with similar issues where the medication worked, but then as soon as she was off it, it came back. And is she like fluctuating kind of between it, where she does what she needs to with her job, but it's still very irritating, and the inflammatory medication worked, but as soon as she was off of it, it stopped working.
Okay, I'll talk to you about the different presentations, all right, how they present differently. What I'm looking for is the overview of this concept. I'm going to keep saying this to you all the way through these Zoom sessions. You look at the big picture first, and then you zoom down. This is really big picture. So it sounds, it's all about the presentation. It's as simple as that. How does it present? There's no real theoretical decision in your presentation, in your examination. You don't have to worry about the theory behind this. It's how does it present? Does it present as a hyperacute tendon problem, or does it present as a subacute or non-acute tendon problem? Is it inflamed is really what it comes down to. Are we okay then? In which case, let's go back to this case, because do not accept the doctor's diagnosis. All right, that's about not off the face of it. The one thing that physicians know about are serious problems, medical problems. What they tend not to know a lot about, which you do, is musculoskeletal problems. So make your own diagnosis. Don't look at the doctor. In fact, I would say, from the perspective of bias, don't even look at the doctor's script. All right, not until you've made your diagnosis. We'll come back to that. So if we're looking at lateral elbow pain, same man, 47-year-old with lateral elbow pain, and can you give me 4 differential diagnoses for this? Write them down, okay? Make sure you write them down, because you need to commit, even if it's only to yourself. So 4 differential diagnoses for elbow pain. All right, we'll start at the bottom. Jacob, Let me have one. Let me put these down.
Yes. One possibility is, as we talked about, some sort of extensor tendon tendinosis. But I know we've already said that out loud, so I was
Well, that's
gonna just add
okay.
one.
Let's add it in. That's fine. So it's
Okay.
Common extensor tendonopathy. All right. We're not in a position really to stage this just yet. So if we say tendinopathy, that covers all the evils of that tendon. Yeah. Okay. John, you've moved to the bottom of the list, so I'm going to get you again.
Sure, that's fine. You can look at a cervical radiculopathy potentially.
Well, all right, we'll do that.
Or some type of arthropathy in the joint itself, if you don't want to look that high up.
No, that's fine. It's just I'm wondering the best way of doing this. All right, cervical radic. All right. Where are we now? Violetta.
Sorry. I just heard John say arthropathy. I also had that, but even a fracture, since we haven't discussed subjective history.
Yeah, that's fine. I'm going to get it wrong again. Ha! Corellia. Did I?
Yes, no, almost,
Hey.
Carolia, yes.
Corellia.
I was thinking,
Oh, Marty, I'm dumb as a brick. Sorry.
no, it's a difficult one. I was thinking going off like cervical radiculopathy or maybe a radial nerve entrapment.
Okay. So neuropathy. Yeah.
Yes.
Any more?
I'm
Maybe
always
some kind of
looking. I'm sorry.
Maybe
Go
some
ahead.
kind of like bursitis.
Is there one there? I don't think there is. All right, but I'm going to put it down anyway because there's a reason for it, even if it's wrong. Bursitis, yeah, okay. Any others?
Something involving like the lateral ligament.
Lateral collateral ligament, sure.
A bone spur.
In the joint?
Around the joint.
What's it? How are you getting pain from it?
I guess, like if it's rubbing on a muscle, or depending on where it is.
Okay. Any more? Don't forget the elbow itself, so an arthropathy of some form. All right. Okay, there's a couple more, but these are enough to be getting on with. The one I want to attack first is a radiculopathy. Not that it's wrong necessarily. Did anybody want cervical or shoulder referral? Or do you consider cervical referral was synonymous with radiculopathy? Kevin, do you think that? Is referred pain synonymous with radiculopathy?
No, I don't. And you actually address this in one of your videos, Jim.
Okay, thank you.
I would characterize, well, let me see if I can sort it out. You tell me how I'm doing. So I would say a radiculopathy is a referred pattern, but not all referred patterns are a radiculopathy.
That's true. Yes, that's true. A radiculopathy actually has 4 or 5 signs. I'm getting an echo here as well. Can everybody hear me all right? Ryan, can you hear me? I think Ryan's got hibernated. Jacob, can you hear me?
Yeah, I can hear you.
All right, thanks. A radiculopathy is defined by signs, actually, well, and symptoms. So it's got to be segmental. This is compromise of the spinal nerve or the nerve root. Yeah, that's the descriptive definition of a radiculopathy. So it's got to be segmental distribution. There's got to be paresis. There's got to be sensory loss. Well, it doesn't have to be. There's hyporeflexia, and there's neuropathic pain. Now, any one of those things will define radiculopathy. The more of those things you have, the more certain you can be that this is a radiculopathy. So apart from the neuropathic pain, this is very objective. So when you're looking at the pain coming from a radiculopathy, it's of one of two types. It's either radicular pain, which is lancinating, zinging electric pain, or it's causalgia, which is really rare in a radiculopathy. But they're the two types of neuropathic pain. Oh, and paresthesia. So if you haven't got one of those three things, you can't attribute the patient's pain to a radiculopathy or a neuropathy, come to that. Now, we haven't said what sort of pain he's having. So it could be neuropathic pain. So there's nothing wrong with that at the moment because we haven't defined the type of pain he's got. And this is one way that you would get rid of the idea that this is radicular pain. Describe the quality of your pain to me. And you're accepting sharp pains, ache pains, anything but neuropathic pain, if it's not neuropathic. And then the lack of signs, neurological signs, will argue that this is not a radiculopathy. Does that all make sense? Anybody having trouble with it?
So when you've tried to have somebody describe their pain, how often do they, I guess, because everybody's pain is different, right? So I've had some times where, they describe, it's describe it differently than what I would expect. But it still ends up being like neuropathic, so how would you go about, maybe differentiating?
Well, neuropathic pain is very rare. If you want to, the causalgia is burning, itchiness, and it can be severe burning, really severe burning. There's a condition called thalamic syndrome where the patient describes that they feel like they're on a spit and being turned over an open fire. It can be that severe, or it can be milder. And there's usually something, it can actually feel like dry twigs being scraped on your skin. That's causalgia. That can't be confused with non-neuropathic symptoms. That's common with neuropathies, peripheral neuropathies, especially with diabetes. The lancinating pain of the that you normally get with a radiculopathy is an electric shock. It's not just sharp, it feels like an electric shock, zinging through the limb, it comes and it goes. There's no aching afterwards, it's just there and gone again. And that is radicular pain. Now, if you get compression of the dura, which is, I think you might be thinking of, you'll get non-neuropathic pain if only the dura is affected. So you'll get an ache, you'll get a sharp pain, you'll get a stabbing pain. It'll be somatic, but not neuropathic. So having said that, how often do you see neuropathic pains, John?
Not often then. Yeah, I think you just have to be very specific with, like you said, the definitions of each and knowing exactly what it is. But yeah, that definitely makes sense. Yes. Okay, good.
So we can have referred pain. In fact, this is normally what you see. Referred pain isn't down the nerve. Referred pain is occurring in the cortex. So it doesn't run down the nerve. The only role the nerve plays with it is to pass the impulses up to the cortex. And then in the cortex now, you're hallucinating the pain. Basically, it's an hallucination, but your brain's hallucinating it. And that's usually an ache. That's usually an ache rather than a very sharp pain. It could be a very bad ache, but it's usually an ache. So this could be that as well. We don't know yet. So the referral could be coming from the shoulder, which shows there's no nerve involved in the transmission of referred pain. It could even be coming, not likely, from the wrist, but it's likely to be coming from the neck. We'll talk about potentiating referred pain later on. Is that okay? Same thing with neuropathies. If you're not getting neurological symptoms, you're not seeing any neurological signs, it's not that. LCL, you need damage done to it. A bone spur is unlikely. And the only way you can really prove that is with an X-ray. The joint problem, it can be that. And what I'll talk to you probably next week is how to differentiate that out quickly and easily. So most likely, this is common extensor pain, but we can get rid of the radicular pain. What sort of pain is this? It's pain, it's an ache, it's a severe ache. I get a sharp pain there as well. Does it feel like an electric shock? No. Does it burn? No. All right, move on. Is that okay? That goes for the neuropathic pain. There's no trauma for the LCL. Bone spur, you can't do much with. Arthropathy, I'll show you an easy way of dealing with that. And bursitis, that's an exclusionary diagnosis. You make that when you've eliminated everything else. All right, so we can't deal with that just yet. Are we good at the moment?
Question, Jim.
Yeah.
Let's say the patient, when you ask about their pain, let's say they come back with it's achy or it's dull.
Yeah.
At this point, given the limited information, would you still look at the cervical spine, do your dermatomes, myotomes, reflex testing, or is that overkill at this point?
Thank you.
Sorry, looks like Jim may have dropped off. Can you repeat the question?
Yeah, so he posed the question, why don't we ask about pain? And he was referring to, we're talking about radiculopathy, to rule it in and rule it out. And let's say we ask about their pain and they come back with it's dull or achy, which would really lean us away from a radicular type referral pattern, correct? So my question to him was this: if they come back with an answer, hey, this was dull or achy pain, would he still choose to rule out the neck and do his myotomes, dermatomes, reflex testing, given the limited information that we have up to this point?
No. If it was me, I'll speak for me. No, that wouldn't be the priority for me at this point. First thing I want to do is establish basically what my differential is and test my hypothesis. Now, collecting that information, I probably would clinically later down the road, just so I can document it. Partially so I can document that this is why it's not these other conditions as part of my bias correction. So, cervical spine, I probably would not look at this person in a first visit, given this information, unless I'm now into a biomechanical cause of this tennis elbow. Can they not extend their thoracic spine? Is there a scapular dysfunction? Is there something else that's upwardly driving this related to their activity? I would get into that. That may be kind of sometimes that second session activity that would do. But the myotomes, like what I would do with this one is a quick scan exam so I can record range of motion, strength, all the data I need in your evaluation. But it's probably at that point part of my bias correction to make sure I didn't miss something. So I started doing, okay, the myotomes, and I go through them, and all of a sudden there's a C7 weakness that's fatiguing. Well, then I got to rethink my cause of this. That, hey, do I have a C7 or a C6, silent radiculopathy given the weakness pattern that's now breaking down this tendon? Does that make sense?
Yeah, so you're going to pick some things up within your scan, basically what you call a scan. Yeah, like an upper quarter screen is essentially a scan. I'm going to look at everything just real quick.
Yeah,
yes, that makes sense.
And it is as part of that, as we'll talk about on Monday too, is it's part of that, I want this information, it's important. I need it to kind of for my next step in treatment, but it's not necessarily all what I need to make my diagnosis. It's really percentaging it. So sometimes where we normally see you graduate, you sit in there, you collect all this information, you do all these tests, you're still kind of lost in your information. It's really hard to sift through. Where the process we're going to focus on is that person comes in and using hypothetical deduction, really, or a process thereof, or generally say hypothetical abduction. There's a reason for that, we can chat. But the process is that I'm focused, and my questions will focus on what is my primary H1 and trying to improve it. And then by doing my bias correction in my exam, making sure I'm not getting into premature closure, making sure that I can rule out radial nerve entrapment, cervical radiculopathy, muscle strain, articular dysfunction. Like my further exam should be me in that self-bias correction, ruling those elements out, but then also looking for what are the other contributing factors in this individual.
Sorry, my computer shut down.
We were just talking about space travel and deep sea diving. Go ahead.
What was the question? Sorry.
The question, go ahead and ask the question. Make sure I don't get the question correct, Kevin.
Oh, did you answer it?
I did, but let's hear your answer.
He did.
See where we jive.
So, Jim, the question that you posed when we were talking about radicular pain, you said, well, wouldn't it be pertinent to ask the patient to describe their pain? So we've we're leaning away from radicular type pain. What if the patient came back to you and said, well, it's dull or it's achy? My question to you is this: would you then continue to screen out the neck or even the shoulder? Would you go on with your myotome, dermatome testing?
No.
Given the limited information that we had up to that point, just the very short description, the onset of pain and the failure of the anti-inflammatories, would you continue to screen out other things at this point?
No. This isn't like if you make a hypothesis, you prove the hypothesis. If your hypothesis is this is being referred from the neck, then you examine the neck. If your hypothesis is that this is a tendinopathy, then you examine the tendon. Now, if you make a list of differential diagnoses, properly speaking, what you should do is prove each one, try to prove each one with specific tests. It's a really cumbersome way of doing it, very cumbersome. So I'm going to talk to you next week about this. Negative differential diagnosis is the way to go when you're trying to generate a hypothesis. And I'll talk to that next week. But if you generate a hypothesis and your hypothesis is referred from the neck, then you investigate that. You're not ruling the neck out, you're actually examining the neck to see if your hypothesis is correct, and that pain is coming from the neck. Not the neck is the cause of a tendinopathy, but the pain at the elbow is referred from the neck. Is that okay, Kevin?
Yes, thank you.
So we've got to talk about this, but this is about generating a hypothesis and working with that hypothesis. Otherwise, you get all over the place. You've got to focus on what you're doing at the time. And looking for etiologies you can't look for etiologies until you know what the pathology is. So you have to make a diagnosis first, and then you can look for etiologies, and you'll be doing a lot of that in the last 4 modules. A lot of that. Okay? Now you have to get away. Let me, Dave, I'll give you the Q&A, if you haven't got it still, the Q&A email, and if they've got any questions they want me to bring up next time, they can email me. Okay? All right, I'm done.